Hello and welcome to the MediGain Advanced MD webinar on healthcare reform. There are usually people that log in 1 or 2 or 3 minutes after we start, so let's just take care of a few housekeeping issues at the very beginning. On the right, there is an area for you to ask questions. So as topic comes up or something comes to your mind, please log it in there and we will address it toward the end of the webinar. I sent out in the chat box that if you'd like a copy of today's slides, please email marketing@medigain.com and we will get you copies of the slides. We are recording this webinar, so we will have a copy of this available for your viewing so that you can share with your the other people in your office. So it's about that time. Hello and good morning or good afternoon, depending on where you are here in the United States. Welcome to the MediGain and Advanced MD webinar on healthcare reform. Convert your anxiety into revenue. I am Clint Hughes. I'm the Vice President of Marketing for MediGain. Let me introduce you to today's esteemed panel of experts. First, we have Dr. Eric Beyer, who is the Chief Medical Officer at MediGain. We have Andy Rowell, who is the District Manager of Advanced MD, Robert Romero, who is the VP of Business Development for MediGain, and April Arzate, the VP of Client Services for MediGain. Today we hope to shed some light and help to get you prepared for all the changes that are happening now and in the future in healthcare. We'd like to start off today's presentation with Dr. Eric Beyer, who's going to give you an overall view of the changing landscape in healthcare reform. Dr. Beyer.
Thanks, Clint. The changing landscape regarding healthcare reform is a very big issue, and there's still a lot of uncertainty in the details. However, while the precise answers are still not clear, there are 5 key themes or trends that are clear and that physicians need to be aware of and start preparing for. The first trend is a migration from fee-for-service to fee-for-value. Fee-for-service rewards volume, but fee-for-value will reward quality and outcomes as defined by the payer. Medicare and many commercial payers are already testing new payment models such as patient-centered medical homes, outcomes-based contracting, and accountable care organizations. Thus, future reimbursement will be even more complex than it is today, since each payer will have its own payment models, incentive plans, and quality measures that the practice must monitor and manage. There will also be a shifting of risk from payers to providers through payments tied to quality measures. Payer-defined quality could be patient outcomes, such as average hemoglobin A1C levels for diabetic patients, or fidelity to specialty society, government, or even the payer's own clinical guidelines. Thus, the practice will need to ensure that the right things are incentivized in its payer contracts and that it has the means to achieve the contracted incentive payments. Third, the fee-for-service reimbursement models will also shift from providing payment for sick care to paying to keep people healthy and managing their illnesses and chronic diseases better. This will require identifying members of a population with a particular health condition and providing health interventions where they are the most effective. A second key trend is the emerging need for even more advanced information technology capabilities in the future. In the future, it will be essential to utilize practice management and electronic medical record software systems which optimize both workflow and user productivity. The practice management and electronic medical record software will also need to facilitate reducing physician-to-physician and patient-to-patient variation in care through flowcharts, adherence to clinical guidelines, and by care coordination with other providers. In addition, practices will need to be able to link clinical performance with financial performance. This will require being able to monitor patient quality measures from various payers and then link these quality measures to contractual incentives that are offered by the payers. New patient engagement software solutions will also be required, since the role of the patient in managing their health is becoming more and more important. These software solutions include patient portals, personal health records, patient registries, and other tools which enlist patients to improve compliance with their care plan. A third principle for success in the future is maximizing work efficiency to lower costs. The lean concept comes from the manufacturing world and is a methodology to streamline processes to reduce cost and increase quality. At its core, lean is taking a 5-step process and turning it into a 3-step process. This improves patient quality by removing 2 steps where an error can occur, and also improves efficiency and cost by eliminating 2 steps of work. Economies of scale also need to be developed to lower cost per unit of work, such as per patient or per relative value unit of work, by sharing overhead costs over more units of work. For example, the cost of a practice manager being spread over 10 physicians rather than just 3 physicians. Economies of scope are cost and efficiency advantages that accrue from having specialized expertise or skills for a particular issue. For example, having one person who focuses on payer contract negotiation and monitoring for multiple physician groups. Thus, in the future, it will be even more important to belong to an organization such as an independent practice association that enables practices to participate in both economies of scale and economies of scope. Third, since you tend to get what you incentivize, it will become even more important for compensation systems in medical practices to promote better productivity and desired behaviors from both providers and their staff. The fourth important principle for future success is the development of clinical service lines. Clinical service lines are generally specialty-specific clinical pathways and care teams. Clinical service lines are now a hot topic with hospitals, and they are looking for physician leadership to develop and manage clinical service lines such as oncology, cardiology, gastroenterology, and geriatrics, among others. Clinical service lines also help to improve quality and efficiency of care by reducing unexplained variation in both patient care and workflow. Another important feature of clinical service lines is patient engagement to promote wellness and preventive care. Studies have shown that patients usually remember very little of what they were told in their physician visits. Clinical service lines facilitate providing patients with clear written follow-up instructions and preventive care instructions at each visit to help patients participate in managing their care. Finally, medical practices should seek out opportunities for new services to provide to hospitals, accountable care organizations, and employers. Clinical service lines appropriate to your specialty are a great opportunity to engage with a hospital, an ACO, or an employer to develop gain sharing or management service agreements which provide additional revenue to the physician practice. The fifth key principle to prepare for healthcare reform is to develop a strategic growth plan. Over 30 million new patients are expected to enter the healthcare system starting in 2014 as a result of the Affordable Care Act. This will create a large influx of new patients with Medicaid and state exchange health plans as their payer. In addition, the influx of aging baby boomers into Medicare and the fact that people are now living longer will increase the number of services required by Medicare patients. Therefore, as a result of the increasing demand for medical services, each practice needs to evaluate what level of new patients the practice can accommodate before it needs to hire more providers or support staff. Recruiting. So while the needs for healthcare services are increasing, some observers have predicted a shortage of over 100,000 physicians in the next 5 years due to physicians retiring or leaving practice, physicians reducing their workload, and from the care needs for new patients entering the healthcare system. Thus, each practice needs to develop a plan to address their future recruiting needs. Finally, physician practices also need to develop a plan for replacing and growing physician and administrative leaders in the practice. This will involve current physician leaders starting now to mentor and develop new physician leaders in the practice, and this principle also applies to key administrative leadership positions in the practice.
Thank you very much, Dr. Beyer. Now we'd like to bring in Andy Rowell, who is the District Manager for Advanced MD, talking about some of the technology we'll need to keep pace with all these changes in healthcare. Andy.
Yeah, thank you, Clint. And I wanted to start by reemphasizing the second point that Dr. Beyer mentioned, which was the requirement for advanced IT capabilities and the need for that going forward. One of those advanced IT projects that you should consider undertaking if you haven't already is the implementation of an electronic health record system. EHR is a large-scale initiative to which the Obama administration has dedicated $30 billion of taxpayer money in order to drive adoption within medical practices. Now, the end goal here is to have an electronic health record network of systems that's easily accessible by both the patient and the patient's caregivers, but also protects patient privacy and is accessible by different providers across the entire spectrum of care for the patient. So this accessibility, or interoperability as it's termed by CMS, is essential, and it's one of the key main driving forces behind the government's Meaningful Use initiative. So why move to an EHR system? Well, we could probably start by looking at how much your existing paper chart system might be costing you. According to the AAO, there are many hidden costs associated with your legacy paper system that you may not be considering today. Some of those being $1.75 per square foot of storage for paper charts. Faxes cost the practice on average 5 cents a page. Medical history sheets cost 15 cents each. Postage, as we all know, is 46 cents per letter. And then replacing a lost or misplaced chart is an even greater expense, averaging about $8 per chart. And then where it's a little tougher to estimate but still should be considered is the long-term potential savings in utilization of office space for other things, reduction of supplies, staff time, and so forth. So where you may think EHR is a large financial investment, you actually are reinvesting dollars every year into your current paper chart system and again may not be taking those costs into consideration. So I'm sure many of you are familiar with the TV show Mythbusters, so we're going to take a page from that show and bust some of the myths that we regularly hear in the industry that you may have also heard about going paperless with EHR. So first, maintaining the existing paper chart system makes sense financially. We've already talked about a number of the costs. The reality is that supply and storage costs, as well as administrative time spent creating and retrieving paper files, are much higher. A busy practice that sees 100 new patients per month on average will spend $42,000 a year maintaining their existing paper chart system. Second, paper chart slips are the quickest and easiest way to enter visit charges. Likely not the case. Paper chart slips are often lost. Manual entry by staff is prone to errors. They're often incomplete, all of which can be limited, if not eliminated, by an EHR system. Third, lost charts and orders and notes are an unavoidable part of a busy private practice. Now, you might think along with caring for your patients, trying to administer an office, that lost charts are just part of the job. Not necessarily so. EHR is designed to make all information accessible in one place and has built-in checks and balances to make sure that nothing gets missed. And fourth, electronic records are not as secure as paper patient files. We hear this one a lot. And the reality is EHR is actually more secure than traditional methods. In addition to high levels of security and data encryption within the system, electronic systems also protect your information from natural disasters. So where you may lose a paper chart easily in a flood or a fire or some other natural disaster, EHR allows you to recover your data with secure off-site storage that exceeds HIPAA requirements by 300%. And lastly, that portability of patient records is a luxury for large practices. Actually, many EHR systems like AdvancedMD provide mobility and access to patient charts anywhere you have an internet connection. So they're being adopted by practices of all sizes because of the low upfront investment. So the real question then becomes, with the high cost of maintaining your current paper chart system and the incentives available by government stimulus as well as time and cost savings out there, how can you afford not to go paperless in the near future?
Thank you, Andy. Now we'll call on Robert Romero, talks about the difference in the benefits of a professional full billing service provider. Mr. Romero.
Thank you, Clint. Everyone should be able to see the full services revenue cycle spectrum and the best practices workflow that MediGain not only promotes, but we use ourselves. It starts with claim scrubbing and goes all the way through submission, proactive claims follow-up. Posting for us really is a trigger for denials management and appeals, all the way through very, very high-end reporting and analytics for our clients. The Affordable Care Act, ICD-10, requirements that are already out there today and some we don't even know about in the future are going to continue to drive needs for education, instruction, information technology, new systems, and services, especially experienced service providers. So a professional full-service billing partner like MediGain, we're really required to be much more of a consultant today than ever before and have a greater breadth of resources than ever before. And we have to apply these to each and every stage along this revenue cycle, because if we don't, there's a chance that something in healthcare reform could actually hinder your practice's ability to collect maximum reimbursement. And we want to turn that around. We definitely want to make the requirements and new technology work for us versus against us. The results that we get measured by our clients are more than ever help us hold us to these standards. Now, there's two specific areas in this billing process that we want to focus on. And the most important steps along this cycle really don't change with healthcare reform. So you have to keep as much emphasis on what happens both before a claim and after a claim is submitted as possible. So if you have a combination of experience in your specialty and the proper software tools, you can improve your clean claims percentage. So maybe some of these changes and upgrades in technology aren't so bad for us after all, you and us. Now, at MediGain, we also know that proper proactive follow-up and denials management make all the difference. And we can document that our clients that use an EHR properly and correctly do get the top reimbursement percentage overall.
And Robert, these kind of benchmarks are pertinent to whether they're doing their billing in-house or whether they're using, they're outsourcing their billing, correct?
Absolutely.
Okay. Let's move on to the next slide, Jill. We have our first polling question here, which we'll see how you rank up with your peers on the technology aspect. Have you ever used a web-based medical office software solution and you have multiple choice, electronic health records only, practice management system only, both A and B, or neither? So we will let you all vote. The votes are coming in real time. So looks like right now we're tracking over 60% of the people are using both electronic healthcare record and a practice management system. About 25%, 20-25% are using neither. Some are with electronic health records only, and about 10% have practice management system only. So we'll leave the voting open for about 5 or 10 more seconds, and then we will move on with the webinar. In your on the side there, in chat and in questions, I gave the email address if you want a copy of today's presentation. Send an email to marketing@medigain.com. So the final results, about 53% use both EHR and a PMS. 25% are using neither. 11% are health records only, and about 8% are practice management system only. So let's go to the next slide, Jill. Now, people have to have a plan, Dr. Beyer. So how do they go about that?
Right, Clint. So the question is, what is your plan to be successful in healthcare reform? And there are really 4 questions to start with. The first is, where does the practice need to be in 3 years, and how will it get there? You need to look at your practice, your specialty, and your local healthcare environment, including payers, hospitals, and other providers in the area, to determine what changes are occurring and what these changes mean in terms of threats and opportunities for your practice. Second, what are the practice's current core competencies, and how do these match up with the core competencies the practice will need in the future? It's good to do a gap analysis to identify the gaps between where you are now in terms of skills, expertise, and capabilities in the practice and where you need to be in the future. Third, what are the current information technologies versus the information technology required in the future? If your practice is not on an electronic medical record, what are the key decision criteria for when you plan to start using an EMR? If your practice is currently on a legacy practice management and electronic medical record system, does that system and the vendor have what you need to succeed in the future in healthcare reform? Finally, who are the partners you can work with to achieve the practice's objectives? These potential partners may be local hospitals, emerging accountable care organizations, emerging medical homes, local independent practice associations, or other physician groups important to the continuum of care for your patients. The key point is to start the process now to proactively look for the partners and collaborators you will need in the future. So what do practices need to start doing now to optimize both current and future revenue? Below are some of the key tasks and objectives. First, assure you have the necessary practice management and electronic medical record software functionality. Some of the questions you may want to ask: does your practice management system have the optimal scheduling, billing, and patient eligibility functionality you need? Does your electronic medical record have the provider and staff productivity enhancements and workflows that you need? Are you optimizing denials management and accounts receivable follow-up? Many practices lose a significant amount of money due to poor denials management and poor accounts receivable follow-up. So look inside your practice and see how are you doing in these areas today, and is the practice up to handling the increased complexity and obtaining payment in the future healthcare environment? Third, maximizing charge capture and patient eligibility verification. Do you have tight processes to capture and bill for all of your service and to verify the insurance eligibility of each patient? Finally, improving coding and documentation and preparing for ICD-10. Is your coding and documentation optimized both to prevent leaks from undercoding services as well as to reduce compliance risk from underdocumenting or overcoding services? Other things include, are you prepared for the new payer and accountable care organization contracting needs? File them and forget them has never worked particularly well for payer contracting, but it will be especially disastrous in the new healthcare environment. Where will you get the expertise to negotiate and accept new payer contracts which have at-risk payments in them? Also, develop the capability for clinical and financial performance reporting with an analytics software. I can't emphasize enough the rapidly growing need for robust clinical and financial reporting and analysis capabilities. You must be able to report and make meaning out of your data. And finally, improve process efficiency and lower costs. Clinical and administrative processes must continually be improved to raise physician and staff productivity, eliminate waste, and to drive out costs, both for your practice, but also for the healthcare system in general.
Thank you, Dr. Beyer. And Dr. Beyer's experience is that of an emergency room physician, and he also has an MBA. And he's out there dealing with doctors in the field every day. Also someone who has actual experience as a practice management professional, and our VP of Client Services is April Arzate, and she has some of the solutions. So what are some of the things that you're seeing out there in the field, April, and how can you direct these people to be prepared for the changes?
Sure, Clint. So at this point, you might be asking, where do I start? Don't let it be overwhelming. Just start with small steps that will gain you the biggest traction. Now, 4 key steps that we've identified and are taking with our clients are automation of eligibility verification and charge entry, preparation for the transition to ICD-10, utilization of PQRS reporting, and risk management in preparation of payer audits. So first, the first step you can take to meet the upcoming challenge is to automate eligibility verification and charge capture. As Eric mentioned earlier, in 2014, there are going to be more than 30 million newly insured patients, 30 million. So gaining efficiencies before then through automation is going to be a key factor to surviving this surge in patients. And with this surge, there's going to be increasing complexities regarding copays, deductibles, health savings accounts, and more. So verification is a crucial step to managing denials and maintaining cash flow. The traditional method of calling or logging into a website to check eligibility just takes too much of your staff's time. The best solution is to use an electronic method that provides real-time, on-demand information and is fully integrated into your system so it's quick and easy to access. You want that information at your fingertips. Now, similarly, you can gain additional efficiencies by automating charge capture through use of an EHR or an electronic charge slip. Providers who use these methods tend to have a higher rate of accuracy as well as faster claim submission times and reduced labor costs. Most systems today offer multiple options, including mobile charge capture. Automating even just these 2 functions that take so much time and are so prone to human error is going to help you help your practice get a handle on the volume and changes that are coming in 2014. Now, next, let's talk about preparing for the transition to ICD-10. The deadline for 2014, and it's not too soon to start planning. One way to get an idea of what the transition will look like is to pick one claim each week and just crosswalk the codes through each step in your claim cycle to see what the impact will be. Look at what the codes are used on, authorization forms, charge slips. Most practices have some type of cheat sheet of your most commonly used codes. Consider, where do you usually go to find a diagnosis code? Is it in your system? Do you have books? Do you have an online subscription? And ask, who is usually the person looking up the code? Is it the provider, the front desk, the biller, the coder? So many other questions are going to come up as you go through this process. And the goal of the exercise is to give you better insight into identifying any person, system, or process and use of a diagnosis code that will need to be addressed in your transition plan. And third, let's talk about Medicare's physician quality reporting system. There's a lot of misunderstanding about the PQRS data reporting options. All eligible providers can report PQRS data whether they're using an EHR or not. And it just seems to be a common misperception that a provider has to be on an EHR in order to participate. Now, I want to focus on claim-based reporting because it's something that you can implement quickly and easily. Just start by identifying the individual or group measures that are most appropriate for your practice to report, and then add the corresponding codes for those measures to your EHR or charge slip. And just a tip, consider setting up each code with all possible reporting modifier combinations as options to choose on the charge slip. That should help reduce the errors and confusion that seem to be common with the various reporting modifiers. Watch your EDI reports and claim scrubber edits for any rejections in case new codes are in use. With proper setup, you should be able to start reporting your PQRS code now to earn the 0.5% incentive for 2013 and avoid the 1.5% penalty in 2015. And finally, prepare to be audited. Even if you're doing everything by the book, you are likely to experience some type of audit. There's several types of Medicare contractors and audits, but I want to focus on the prepayment audit as it's currently a source of great frustration and revenue disruption to many providers right now. Be on the lookout for requests in the mail asking for medical records and make certain that you provide them before the deadline. Otherwise, not only will you not be paid for that service, you may actually trigger a post-payment audit of previously paid claims for the same provider. So be sure to send progress notes, operative notes, test results, any documentation that supports the claim. One of the most proactive steps you can take now to protect your practice is to do an internal assessment. Whether you use your own coders or a consultant, you should confirm that you are in compliance with Medicare rules, especially for medical necessity and documentation requirements. One of the biggest faults that contractors are finding is failure to appropriately sign the records, which should actually be one of the easiest requirements to comply with. Now, we've conducted internal audits for several clients to ensure they're meeting those requirements, and we've also successfully assisted several in submitting and tracking appeals for both prepayment and post-payment audits. This is a tedious and often confusing task for billing staff to handle on top of their regular responsibilities. So it's important to be able to identify when an audit has been initiated and track the results. Now, these are just a few of the key steps to help you prepare for the changes ahead. It barely scratches the surface. So I hope this one at least gives you a few ideas of where you can start.
Thank you, April. Okay, we're going to be taking another poll here because we've been talking about technology. And so how are you using it? Are you presently doing your billing in-house? Are you using a professional billing company, or is it a combination of both? And this kind of gives us an idea of how you're starting to prepare for ICD-10 and how you're incorporating technology. So we'll leave the voting open for a little while longer. Right now it looks like a little over 50% do your billing in-house, about 25% use professional billing company, and about 15–20% use a combination of both. Okay, we'll keep the voting open here for about 5 or 10 more seconds. Remember, feel free to continue to ask your questions there on the side where it says questions, because we do have a question and answer session coming here at the end of the webinar. Okay, so let's go ahead and close the polling now, Jill. Right now it looks that 57% of you all doing your billing in-house, 23% are using a professional billing company, and about 20% use a combination of both. So, Andy, what kind of technology solutions are there out there to help getting people prepared for all the upcoming changes, and especially ICD-10?
Absolutely. So there are a few components that it's critical that your software platform offer you. So, for example, the Advanced MD software platform gives you a unified software experience at multiple levels. First, the front office level. April mentioned the critical importance of eligibility checking before the patient shows up. It's important that that's included in your software platform. The Advanced MD system also offers cloud scheduling, so everyone everywhere is updated in real time. Integrated credit card processing and credit card on file helps you get paid quickly and keep your AR low. Now, as I discussed on my previous section, a complete and certified EHR is critical, and it must include a few components. Integrated patient portal, so that your patients can interact with your office from home in a secure manner. A health watcher module, which gives you reminders and alerts for managing health maintenance protocols for your patients, and of course, an electronic prescribing module. Next, an increased need for mobility. So no matter what software you use, the value would not be fully realized unless mobility and access to patient data is fast and easy. This is where a cloud-based system gives you a huge advantage. So you get tools like scheduling, charge capture, EHR, all delivered on an iPad or laptop to make your life much more manageable. So working from remote places like home or the hospital is just as easy as working from your office. And then finally, automated charge capture gives you a quick and secure way to communicate charges to a partner like MediGain through multiple channels, including mobile applications, so that you get paid quickly. And having that fully integrated cloud-based software system, again, is an integral part of running an efficient office. And just as critical in getting you paid quickly will be the conversion to ICD-10. One of the things I hope you take away from this webinar is an urgency around ICD-10 compliance. I'd recommend speaking with your current software vendor, and asking them where they are with ICD-10 preparation and groundwork within the software platform. And just to give you an idea of what kind of investment this will be for a software company, ADP's invested $10 million into R&D as well as engineering to ensure compliance within the software for ICD-10. Now, this slide that you're looking at now is a snippet of our ICD-10 readiness timeline, and it has target dates for each milestone leading up to the conversion deadline. So I definitely would recommend visiting this site. It's myicd10.advancedmd.com, and you can review the target dates, benchmark yourself to ensure that you're going to be ready for the ICD-10 conversion well ahead of the deadlines in place.
And I put that URL there in the chat box. And remember, all the attendees today will be getting a copy of the 5 things you need to do to start on your ICD-10 transition, the 5 things you need to start doing now. So back to Robert, how can everybody is concerned about getting paid and reimbursements and how healthcare is going to be affecting that? Robert?
Thank you, sir. So even with all of these changes, and maybe even because of some of these changes, our MediGain clients and the market overall is demanding more than ever from your services providers. And the number of practices working with a professional billing partner has begun to increase almost exactly equal to the complexities in billing and the increase and the changes. So a few things that MediGain does to make absolutely sure that we get off to a positive start with our new clients is a 2-year practice analysis. We dip into the current data that you have, and we want to run a number of tests on your past production, reimbursement, coding, and accounts receivable. Example, if I asked all of you what your payer mix was, you'd be able to recite it immediately by charges. And if you think a minute, you could give it to me by revenue. But what one measure I want to see is what is it by reimbursement ratio. So if we normalized all your charges to your payers to, say, $1, and then we figured out exactly how much money we get back, we want to make sure that your top payers by volume are also your top payers by reimbursement ratio. Now, when we do an EOB review and analysis, we're obviously looking for a pattern of denials that can help us make improvements in your billing cycle going forward. When we do a front desk process review, we start with your own policies and procedures, make sure that they're actually in place, try to add some best practices with that. Now, when was the last time you had a full coding review or even a mini coding review? We want to start with this with all of our new clients to make sure that nothing has been updated or changed, or the ball hasn't moved from one payer or another since the last time, and it also helps us get to know your practice. So if I was going to give you a best practices summary, I would say for those of you that are out there that are going to do this on your own, or that you're going to hold your current biller to some of these standards, or hopefully some of you are going to engage MediGain for some of these, you absolutely want to combine a full services billing partner with a chief medical officer, experienced certified coders in your specialty, experienced client service managers who are all former practice administrators. Add that to a top-tier cloud-based practice management system and EMR like ADP Advanced MD. Blend in your own knowledge, and I guarantee you, you will make more money faster.
Robert, just a question as we're getting ready for this next poll. This is just a general because we're going to be doing more webinars and drilling deeper down into each one of these points. So please fill out this question about whether you'd like more information. But Robert, what do you see as an overall average about reimbursement? Because that reimbursement ratio, I'm sure that perked a bunch of people's ears up. What's a good rule of thumb?
It's one of the biggest questions people ask. Besides, what's my services fee rate? But the MGMA quotes, and it changes a little bit every year, but they quote 90, 91, or 92% of your contracted amounts should come back to every well-run practice. Now, a professional services company like MediGain really is held to a bit higher standard. Our typical client should be able to receive 95 or 96%, and if they keep great medical records, and especially in an EHR, those should approach 98 or even 99%. Sometimes that takes time to get the client used to our billing processes and for us to adapt to know the client's full range of services, but it's almost always going to pay for itself in the long run.
And this, okay, so let's see, the vast majority of y'all, yes, well over 90% say that you want to be notified about more webinars, and we will let you know. This is the first of a series of MediGain Advanced MD webinars. Let's move to the next slide, Jill. So go ahead and click, and let's show them all the panelists again. This is our question and answer period, and I'm going to throw this first one out to Dr. Beyer, and please put your questions there on the right, and we will get to them as we come through. Dr. Beyer, one of the questions that came in is, okay, if somebody, say a diabetic, does not comply with what the practice tells them, can the practice be punished in these new healthcare reform guidelines?
So I think there's a couple of important points there. One is that brings up the importance of contracting, because I think different payers are going to have different models, and some of them are going to depend on objective patient outcomes. So if your patient is not following or is not complying with their care instructions, and their hemoglobin A1C is significantly out of range, then that could come back and you would receive a lower reimbursement for that. So that would probably not be a good payment model that you would like for that type of a payer. But secondly, I think it's important that they're really trying to incentivize best practices. So evidence-based medicine and things that the practice can do to decrease the amount of variation in clinical care or care from patient to patient. So I think the key message for physicians and medical practices is how can you narrow down the clinical variation in patient care and between physicians, because oftentimes there's significant variation in the way physicians care for patients, so that you really adhere to best practices, evidence-based medicine, and really try to optimize the patient outcomes that way. But again, there still can be a component that if the patients are not complying with their care, that could potentially, under some models, impact what the reimbursement would be to the provider.
Oh, great. Thanks, Dr. Beyer. April, here's another one that came through, because you all talked about the technology, about EHR and PMS, and I'll break this question into two. So if an office is right now all paper and they don't have any of the technology, how long would it take to migrate to a system where they're doing everything with an EHR and practice management system all combined? Or if they're on older systems that can't handle what is their needs for the future, how long would it take them to change and get up to speed? So from ground zero, and then if they're already halfway there, I guess, how long? Because you've been out there in the field working with the doctors.
Oh, sure. So, a lot of that depends on the system that if you're going from paper to a system for the first time, you don't want to try and plan and be paperless from day one. It's not realistic, and it would just drive you crazy to try and even get there. Set some realistic goals for yourself. We talk about baby steps a lot with our clients. Let's look at the project and let's plan, what do you think is realistic for your staff to be able to learn and accomplish by certain dates? And so another part of, answering your question is, what are the capabilities of your staff? If they're all very fluent with, computers, and they're very comfortable navigating, they may pick up very quickly. If you're on a paper system now, they may perhaps have more challenges translating and finding, even the fields they're looking for on the screen that just used to be a pen and paper. So realistically, plan for at least 6 months, I would say, and Andy may have some better statistics based on actual implementations with A&D clients. But my recommendation would be allow at least 6 months for a full, and I say full, a transition from, learning the system, getting it implemented, and really 6 months almost from the day you go live. You have to give yourself a training period, and you go live, and a lot of practices wisely choose not to try and go live on a new practice management system and a new EHR at the same time. That's a lot of behind-the-scenes training and setup and conversions that have to happen. It can be done, and I think, the most successful way is if you just sort of plan ahead and just know you're not going to be completely paperless on the day you go live.
So, Andy, April brings up a good point. Is that the kind of time frames that you're seeing out there in the field?
Yeah, absolutely. I agree with April on everything she said there. I would add we do typically recommend a phased approach to implementation if you are overhauling the entire practice management and health record side, both the billing and the clinical, that you attack the practice management side first, get that in place so that there's no interruption in any kind of billing or revenue, and then tackle the electronic health record component. So the nice thing is if you already have a billing system in place and you're just doing the EHR, like April said, you're going to want to give yourself a few months at least for converting over to a paperless environment and making that transition.
Okay, here's an interesting question that I'll throw out. maybe Dr. Beyer, this is in your wheelhouse. Have you heard that the government is searching like a needle in a haystack to find ways, i.e. keywords, errors for practices to have to refund Medicare and Medicaid payments?
I'm not aware of anything like that. That's not to say that the government is not taking some significant search efforts. I did read an article a couple of months ago that said that for every dollar the government spends on its fraud and abuse prevention and techniques to try to find fraud and abuse, it makes $7. So this is a real money-making activity for the government. So I do expect there's going to be a significant increase in audits in the future and in techniques that the government uses, such as the RACs, in order to try to pick up more payments that they think have been paid inappropriately.
Okay. Robert, I believe this one's for you. The question is, what's the average annual cost for a professional billing service, and how can a combination of the technology and a professional service, what does that mean to a practice's revenue?
That's a great question, and it's a popular one too. For a full-service company like MediGain, our rates can really range quite a bit. They can be as low as 4.5% or as high as getting close to 6%. We'd like to say that we're going to be slightly below market and provide, obviously, as you see today, a much greater full service. What makes that range, if you can pinpoint yourself in that range, it's typically by specialty. And forgive me, but the poor pediatrician that sees hundreds and hundreds of patients a day at a very small charge amount per patient really is at the highest end of the range. Who really gets good value are probably the specialties that have a high charge per encounter, rheumatologists, neurologists, surgery-based practices, oncology. They're going to be tiered towards the lower end of that range. It's really just simple algebra as to how many transactions we need to process with what manpower and what's the lowest rate that we can provide for that. And I'll tell you the one question I think we get also asked in combination with this one is that what if I have an older technology today and really need to upgrade to a system like AdvancedMD? AdvancedMD is so much more efficient for a large-scale company like MediGain to work on that, and we're so much more efficient and get better results on the top-tier systems that we will actually provide AdvancedMD's practice management system along with our services. So if it's a matter of it's time for an upgrade and it's time for you to look at using a professional billing service, then Clint, I'd love for our 800 number to be out there.
It's right up there right now.
Thank you.
And so, that's in addressing the second part. From what I hear from you and Andy and from Dr. Beyer and April is when you have the combination of the two, whether it's in-house or a combination of the technology and a outside provider, the secret is to maximize your reimbursement and to do all the things right at the beginning when you're submitting the claim and then following up at the end, or else you're letting money fall through the cracks. And I heard before, like you said, MGMA said around 90%, and where some of our clients are getting 97, 98. How much is that in real dollars to the bottom line each year?
I think it really depends on once again, the type of specialty. For a family practice, it may only be a few $1,000s a month, but to that type of practice, that could actually have a great impact. To a practice that is half surgically based and half clinically based, it could actually be an awful lot of money and make a great impact. So 4 or 5% increase typically pays for your professional billing service. But a 10% increase could mean an additional 5% of the practice's overall revenue coming to the bottom line.
Interesting. Okay. We have a few more minutes, and we have more questions coming in. Please keep sending them. Here's one, I guess, Dr. Beyer, are you able to address changes, if any, to accreditation requirements such as CARF or JACHO, initial versus renewal after 2014?
I really don't have any information on that, so I'm not aware of any accreditation changes. That's not to say that they're not happening, but I'm not aware of any on any of those organizations.
One thing that you talked about earlier, and we have a question on that, is about panels. And so is there a cost for joining these panels or independent, the IPOs? And is there any way to get reimbursement on those?
So there are different models that are out there. The Independent Practice Association, there are a number of areas of the country that have had independent practice associations or IPAs in place for a while. And one of the areas that they usually provide significant value to their members is when it comes to payer contracting, that they are an organization that often has the sophistication and the ability to negotiate with payers, and then they do that on behalf of their members. So I think what the practices need to do is look at, what are the resources they have available locally or regionally or even within the specialty. So going to your specialty societies and talking with your colleagues. And if you don't have anything available locally, are there some opportunities for like-minded practices to come together and start to form some of these organizations that will help give you some of the scale that you need to get the benefits that some of these large organizations can provide.
Thank you, Dr. Beyer. Andy, I think here's one for you. What are the issues on bringing an end-of-career, in quotations, physicians on board with EMR? What are some of the issues you see there?
Well, generally speaking, you would have that type of an issue with an electronic health record that is an on-premise solution that you're going to have a huge upfront investment in. With Advanced MD and a lot of the other web-based systems out there where you're generally going to be paying on a per-provider subscription basis, it's really just a training issue. Once they're trained and up and running, they can practice until they're at the end of their career and have retired. And it's as simple as just sending an email and saying they're no longer practicing and removing them from the subscription base. So it's definitely not difficult when you're dealing with a web-based platform to add and subtract providers to that base, whether they're at the end of their career or just starting out.
Okay, thank you very much, Andy. I guess this one is for you, Dr. Beyer. One of our attendees is concerned about the art of healing being overshadowed by the need to comply with demands of the insurance companies, etc.
Yes, I think the issue again is the art of medicine is always going to be very important. But I think what payers have found, and what we know in general, is that when there's a significant amount of variation in care, if that variation is not justified for clinically appropriate reasons, oftentimes the costs are higher and the outcomes are poor, so the quality of care is poor. So the payers and the government are really going to try to incentivize or disincentivize. So incentivize adhering to best practices and evidence-based medicine, or create penalties if you step outside of those guidelines without having justifiable reasons. So I think the art of medicine is always going to be important, in clinical documentation to help substantiate why you are stepping outside of perhaps clinical pathways or guidelines will be important. But the art of medicine will always be there. But I think the science of medicine will need to be followed more closely based on evidence-based medicine and clinical pathways than perhaps it has been in the past.
Thank you, Doctor. April, here's a question. What do you see as the financial ramifications of the conversion into ICD-10, and how can the offices prepare for that, and what should they think about financially?
Oh, sure. That's
you
a great
mentioned
question.
something earlier about like some kind of fund or something?
Right. So So we saw the conversion to 5010 at the beginning of 2012, and even though there had been significant preparation by practices, by vendors, clearinghouses, payers, we still saw problems. There's nothing that's going to be foolproof, and I think that it would be safe for everyone to plan that the conversion to ICD-10 will have its own inherent problems as well that could have a disruption in cash flow. So our recommendation is that, just plan ahead, be conservative, plan ahead, and think about, having maybe 2 or 3 months of cash reserves in case one of your big payers, whether it's Medicaid or Cross or one of the other commercials, in case one of them ends up having a significant problem or delay once we actually turn it on, so to speak, on October 1st. It's just something, it's something every practice has to plan internally. There's not going to be any kind of assistance fund, so to speak. We're pretty much, just like with 5010, we're going to be at the mercy of our own internal monitoring mechanisms to survive whatever might happen with the clearinghouses and the payers. And again, this is just another reason you really want to be in touch with your vendors and make sure that your billing team and your coders and your physicians, everyone understands what the transition to ICD-10 means, and you have a plan so that you have some kind of confirmation that, yes, your clearinghouse has been testing ICD-10 codes, or yes, you see that the codes have now been loaded in your own practice management system. Just safe to plan ahead that there probably will be some as we hit that date.
Great. Thank you, April. And just to remind everyone, you will be getting a copy of the book, The 5 Steps You Need to Take for ICD-10 Implementation Now, written by Advanced MD. You have our email address up there, so if you want a copy of the slides presentations, shoot us an email. If you have any other questions, I know there are some questions that we're going to be investigating for some of the attendees out there and getting back with you. It was some things a little bit more specific to you and your practices. I'm just going to ask the panelists for a brief 15-20-second recap of the major takeaways of today's presentation. Dr. Beyer.
Thanks, Clint. So I would say 2 things. I think one of the first things is that practices need to be aware of some of the key themes and trends that are happening with healthcare reform and start preparing now. So part of it may be identifying who are the potential partners that you can work with, the technology you'll need, but really start engaging in the process of preparing your practice to be successful in the future. Secondly, I think the PQRS system is a good benchmark that you can start looking at of what future payment is going to be like. So here Medicare has incentivized certain types of behavior, so tracking information, specialty specific, and they've provided an incentive to start with, but then they're transitioning that over to a penalty for those practices that don't comply. So those are the types of payment models that I think we're going to be seeing more and more of the future. So again, it's adhering to clinical best practices as defined by the payer, in this case the government, and then being able to have the tracking and reporting mechanisms to share with the payer so that you either get the incentive or you prevent the payment take back.
Andy.
Yeah, I would say just don't be afraid to implement new technology in your practice, even though there may be some initial pain with implementing that. It definitely will be beneficial to you in the long run. And again, back to my earlier comment, ICD-10 is coming. It's definitely not too early to start preparing now and to be speaking with your current vendor, or if you're looking at a new system, a new vendor, to make sure that they are ICD-10 compliant and that everything is in line there.
Robert.
If you need help, please ask. I know we've talked about a lot today, but as a full services provider, we would love to help each and every practice we can, whether it is from a consulting perspective, and we've got someone from April and Eric's team working directly with your practice, or whether it's engaging with MediGain to help you with your day-to-day billing. If you're serious about that part of it and having a top-tier system included with the process, we'd love to do a 2-year practice analysis and see if we're a good fit for each other.
And April.
do your internal assessments. Dip your toe in, jump in, take a claim, walk it through ICD-10, get a feel for what it looks like, what it's going to feel like, and do a coding review. Look at your medical documentation. Don't assume everything's just good, just as good as if it was maybe when you did one 2 years ago or even last year. Do an internal audit.
Great. Well, thank you all very much for attending today. There's the email address if you want a copy of the slides. And we will be also send us suggestions about other topics you would like us to drill further down into to help you prepare for ICD-10 and all the changes that are happening now with the healthcare reforms. I'd like to thank all the attendees for being here today for us and the panelists for your contributions. Thank you all very much, and that will be ending the presentation now. Let us know how we can help.